So we can move to the next speaker.
So the next speaker would be Tomi from Helsinki University Hospital.
Good morning, everyone. I know it's early, and I truly appreciate you all choosing to join this session over the potentially more exhilarating option of another cup of coffee. So I'm honored to be here and share our pioneering study to address the pervasive fear of falling, abbreviated here as FOF, among the older people, with a demographic prominently composed of women, 90% of the patients. We go deep into understanding how FOF influences the impact of performance-based test scores, the PPTs, and how it interplays with the success of the Multifactorial Force Prevention Program, abbreviated here with the MFFP. So, no financial interest to declare. And what is the public health concern? Statistics indicate that falls are the leading cause of injury-related deaths among those aged 65 and over, and with a steep trajectory in hospitalizations and morbidity. The financial ramifications are significant, costing billions of dollars annually, worldwide, and with aging population demand our immediate and sustained attention. Then the research objective and background. From previous randomized control trial of the same MFFP intervention, we learned that it reduces falls about 24% from this population. But what we don't know is how much the MFFPs impact the PPTs. The PPTs has the strongest evidence to detect the risk of falls. And our objective represents a stride forward in the realm of physical and rehabilitation medicine. So the study aim was to assess the impact of FOF during this MFFP intervention. And our hypothesis was that FOF would be linked to less substantial improvements in the PPTs. 10 methods. Through a retrospective register-based study conducted in Lahti, Finland, we observed 527 older adults. Mean age was 78 and standard deviation was 6 years. And they enrolled in a falls and osteoporosis clinic program. The physiotherapist gave a tailored individual exercise plan. Patients were educated how to prevent falls, and program included an extensive and comprehensive assessment of health, bone health, nutrition, exercise, physical performance, and fall risk. Also, medication review and home hazards checkups were included if necessary. Other healthcare professionals such as memory nurses, ophthalmologists, or dentists were referred when necessary. For the statistics, we used ANCOVA to capture the between group changes, and for the overall performance change, used the composite score. So these two groups, with and without FOF, differed significantly at baseline in self-rated health and mobility, in self-rated balance difficulties, and in self-rated visual analog scale for pain. This table 1 here shows the baseline PPTs for the maximum walking speed, 5 times sit to stand test, single leg stance, and hand grip strength of the included 276 patients, categorized in 2 groups based on single item question regarding FOF and PPT's changes over the year. At baseline, the with FOF group showed a lower maximum walking speed and no significant improvement post-intervention in either group. At baseline, the FOF group was lower by 2 seconds in the 5 times sit to stand test than those without FOF. Although the FOF group showed a slightly larger improvements in 5 times sit to stand test, the difference was not clinically or statistically significant. Change was a minus 1.6 seconds. For single leg stance, the with FOF group had a 1 second shorter duration at baseline with no improvement in balance in either group, and no improvements for hand grip strength either. The intervention showed a small but positive effect size on the total composite score change of the 4 physical performance-based tests. This underscores the complexity of FOF's role in physical rehabilitation, suggesting FOF hinders performance change, probably through the influence on motivation and participation in exercise programs. And what are the clinical implications? While FOF direct impact on physical performance changes was small, the MFP remarkably prevented the expected age-related decline in physical function across all patients. Interestingly, both groups, irrespective of FOF, exhibited threshold performances in tests that traditionally predict a persistent fear of falling and risk for falls. The group with FOF started weaker, and throughout the intervention they remained weaker. This happened for 1 year. Imagine the next 10 years. Then the challenges and limitations. We are openly acknowledge the limitations inherent to this quasi-randomized design of our study. Additionally, the study did not account for a range of factors that could potentially confound the outcomes, such as mental health or medication use. Establishing a solid causal link between FOF and improvement in physical performance remains an area for further investigation. And what about the other future directions? Of course, the prospective longitudinal studies with larger and more diverse samples are essential for unraveling the complex nature of FOF and its impact on physical performance more than a year. The small effect size is in composite scores between groups along with the overlapping confidence intervals underscores the need for more specific subgroup analysis. A rigorous evaluation of the real exercise volumes undertaken by both groups is also warranted. And because the group with FOF started with more pain and ended up with more pain. The pain management of this group is warranted. It's time to wrap up. Our study signifies a leap in understanding the impact of fear of falling of performance-based test scores during a multifactorial falls prevention program. And the dialogue we continue today might shape the future of geriatric care, and I welcome your questions and insights. Thank you.
Thank you. There are other questions from the audience? I have a question for you. Only for the patients are you a physical therapist?
Yes.
Right? Okay. Only for the patients to the physical therapists. Is Cankarjev
There was like an open door. Everybody who has a risk for falls come, and then they were reviewed if this weekly osteoporosis index was enough or like risk. Right?
So-
Science will.
So were you, assessing patients that were coming to your clinic for other reasons?
No, these were only for osteoporosis and falls.
Okay.
Specifically designed.
Any other question?
I have one question. Maybe I missed information, sorry. But how did you assess the fear of falling the fourth?
It was with the single item question. Okay, do you afraid of fall?
No.
And do you assess the near falling? I mean, the near falling are those when a patient tells you that your friend feels that he's going to fall and is actually not doing it in the end because he managed not to fall down. Did you assess it?
The falls?
The near falls also because
No, I don't know.
no. Okay. Okay, thank you. Any other question? No. So thank you very much
Thank
for
you.
your presentation.